Bismillahirrahmanirrahim. Senior officers, faculty member, and my dear colleagues, Assalamu alaikum. I, Dr. Muniba Said, Registrar Dermatology at Tertiary Care Hospital, Kuwait, will present a case from drugs to disaster, shattered skin, unbreakable spirit, battling toxic epidermal necrolysis, prepared under kind and able supervision of Professor Dr. Nazia Ahmed, consultant dermatologist, for which I am highly thankful, ma'am. The objective of this CPC is to highlight the importance of early detection and timely management of life-threatening condition and to create awareness about judicious use of high-risk medications. The sequence of my presentation is as flashed. Coming first to case presentation, a 37-year-old lady presented in Tertiary Care Hospital, Kuwait, on 9th December 2024 with complaints of fever for 5 days and skin and mucosal rash for 4 days. She was in usual state of health 5 days prior admission when she developed high-grade fever that was abrupt in onset, intermittent in nature, without riders and chill, and associated with generalized body aches and malaise. She developed sudden redness of the eyes, followed by pain and painful red rash with blistering on her face that spread to involve her trunk and extremities over a period of 4 days. Then blister formation occurred over the lips and oral cavity became eroded. She also had history of dry cough that was gradual in onset, constant throughout the day, and was associated with mild respiratory distress with no aggravating or relieving factors. She had history of pain in her right foot for past 3 months, for which she was taking allopurinol and atorvastatin for 1 month, prescribed by a general physician without establishing a diagnosis. On detailed inquiry, patient also gave history of lower back pain that was radiated to her right lower limb, off and on for 1 year. Next day, after developing rash, she visited her treating consultant again, but he did not stop any of her medication. On day 3, she visited a dermatologist who stopped her medication, and on day 4, she presented in our hospital with shedding of sheets of skin leading to large wounds. She had no known prior drug allergies and belongs to upper socio-economic class. On general physical inquiry, a young female in obvious distress with temperature of 101 Fahrenheit and regular pulse of 126 beats per minute, along with generalized non-pitting edema. Skin and mucosal examination revealed multiple purpuric macules and patches on mentioned part of the body. Rash covered more than 50% of total body surface area. Few intact flaccid blisters on face, chest, along with large erosions on trunk and extremities were noted. Nikolsky sign was positive. Eye examination revealed conjunctival hyperemia and congestion. Hemorrhagic pus was deposited over eyelids and lips. Oral mucosa was also eroded. Here, you can appreciate skin and mucosal involvement in the patient. Large erosions can be appreciated on back and front of chest. On auscultation, there was expiratory wheeze. So based upon history and examination, the differentials of Stevens-Johnson syndrome and toxic epidermal necrolysis, pemphigus vulgaris, and staphylococcus scalded skin syndrome were known. On investigation, her weekly complete blood profile showed decline in her hemoglobin level and red blood cell count due to blood loss from the erosion that improved with daily skin care. Initial liver function tests were deranged that gradually improved with treatment. Her first sample of random blood glucose was 14.2. CRP and muscle enzymes were also elevated. Later on, these parameters normalized with treatment. Swabs taken from vaginal skin were negative. Chest X-ray was unremarkable. Score 10, a prognostic score calculated on day 1 of admission was 4. On day 5, this score declined to 2. So based on these findings, a final diagnosis of toxic epidermal necrolysis was made. For management, the suspected culprits, allopurinol and ethoricoxib, were identified and stopped. Then patient was shifted to ITC for monitoring and supportive care. Barrier nursing was provided along with fluid resuscitation to counteract hypovolemia. Daily screen dressing was done by applying paraffin gauze. A multidisciplinary team was made that involved clinicians from dermatology, intensive care, ophthalmology, skincare nursing, and rehabilitation. Patient received tablet cyclosporin 100 mg 12 hourly, injection methylprednisolone 1 gram IV daily for 5 days, injection linezolid 600 mg 12 hourly, and injection meropenem 1 gram 12 hourly. Saline washes and petrolatum impregnated gauze dressing with polyfix was done twice daily under skin care and can be appreciated in this video. After receiving meticulous care for 2 weeks, patient's condition started to improve. Rash progression stopped by day 3 of admission. Recapitalization started on day 10. Mucosal lesions healed with substantial improvement in her appetite. Eye redness improved gradually with slight difficulty in her right eye opening, and she was discharged of oral medication with weekly follow-up. Significant clinical improvement is appreciated in these images. Here you can appreciate healing of eroded back. On discharge, patients and attender were given written information about drug to avoid along with a medical alert bracelet. Drug allergy was documented in patient's discharge note. Patient advised regular follow-up in skin, medical, and ophthalmology clinic for proper care of long-term complications. To summarize my case, a 37-year-old female patient on allopurinol and ethoricoxib presented with fever and skin and mucosal rash. Workup was done and treatment was started on line of 10. Patient condition started to improve with regression of rash, and she was discharged. Now coming back to case discussion. STSM10 are rare life-threatening severe cutaneous adverse reaction characterized by extensive bullae formation and sloughing of skin. Culprit drug is identified in 85% of the cases, and infection can also be rare causes. STSM10 share same spectrum of disease, but 10 involve more than 30% body surface area. Stevens and Johnson's first reported this syndrome, followed by Loy, who coined the term toxic epidermal necrolysis. The incidence of STSM10 is approximately 1 to 2 cases per year. It occurs in all age groups. There is increased incidence among the elderly, with slight female predominance. Researchers in Taiwan have shown association of carbamazepine with HLA-B 1502 and HLA-B 5801 with allopurinol. These are drugs which are responsible for 50% of the cases. And you can see allopurinol is the leading drug. It also includes ethoricoxib. In pathogenesis, the drug and its active metabolites are presented to antigen-presenting cells, which further interact with HLA protein. Upon this interaction, the cytotoxic CD8 cells are activated. They produce various chemokines and cytokines. These chemokines and cytokines have the ability to cause tissue cell destruction. Moreover, cytotoxic lymphocytes and natural killer cells invade the cell and cause blister formation. There is a latent period after initiation of drug. This latency is typically 7 to 10 days, but can range from 5 to 28 days. In prodromal phase, patient is unwell with fever, malaise, and prostration. The earliest skin lesions are atypical targets of purpuric macules. Vesicles or fluid-filled blisters along with large area of confluent redness may develop. Gentle lateral pressure can cause lesional epidermis to slide over the dermis, and blister and shearing induce epidermal detachment. Painful acute inflammation of the mucosal surface of the eye resulting in visual impairment. Oral involvement is usual with blistering and ulceration that cause impaired oral intake. Mucosal involvement may extend up to oropharynx, larynx, respiratory tract, and esophagus. In urogenital tract, there is mucosal redness, blistering, and annoyance. In acute phase, pain and urinary dysfunction are common. One quarter of patients develop pulmonary signs characterized by dyspnea, increased respiratory rate, and bronchial hypersecretion. Here, slide shows mucosal and skin involvement in the patient. A number of disorders can present with blistering of skin and mucosa, as described here. Complications can be acute and chronic. In acute phase, extensive detachment and can occur, leading to thermoregulatory failure and hypothermia. Detachment of 50% body surface area will lead to water loss of about 2 to 3 liters per day. That can cause end-organ hypoperfusion and acute kidney injury. Possible hematological complications are anemia and leukopenia. Hypoalbuminemia and hyperglycemia may also develop due to stress response and high-dose corticosteroids. Bronchial epithelial sloughing causes erosions in the airway, and commonest life-threatening complication is septicemia due to infection of the skin. Survivors from acute episodes develop delayed sequelae in skin. Post-inflammatory hyperpigmentation may persist. Shedding of nail is common, and telogen effluent occur in 20% of patients. Patient with chronic eye involvement may require lifelong management for dry eyes and conjunctival ulceration and may suffer permanent visual loss. Oral mucosal scarring is common. ANA-Rho negative sovereign-like syndrome is believed to occur in about 40% of survivors. Pulmonary, gastrointestinal, and genital complication can further compromise quality of life. It appears that many survivors of STS and TENS suffer psychological sequelae, including post-traumatic stress disorder. In 2000, Vestugi and Green published a validated prognostic scoring system by name of Score 10. It comprises of 7 parameters. Score 1 is assigned to each independent variable, and for score of 7, the predicted mortality is 98.5. A set of investigation is needed to substantiate the diagnosis, exclude other blistering dermatosis, and to identify systemic complications. Following lab panels should be run, along with swabs from lesional skin. Photograph of skin should be taken, and extent of redness in epidermal detachment should be recorded on a body map. Skin biopsy for histopathology shows full thickness keratinocyte necrosis, basal cell vascular degeneration, and subepidermal bulla formation. Dermis may show mild infiltrate that comprise of lymphocyte and histiocytes. In management, supportive care is the mainstay of treatment, which include identification and cessation of positive drug. Depending on severity, the patient may be transferred to burn center or ICU. Supportive care includes peri-nursing, oral, ocular, genitourinary, and wound care, pain management, airway management, fluid, electrolyte balance, stress ulcer prophylaxis, nutritional support, and DVT prophylaxis. Optimization of each measure is necessary to achieve best outcome. Maintenance of aseptic environment is critical, and consideration should be given for prevention of sepsis, which is leading cause of mortality in these patients. The active pharmacological therapy efficacy is still unknown. In early acute phase, systemic interventions involve IV use of immunomodulating drugs, including IV immunoglobulin, systemic steroids, and cyclosporin. Patient may require long-term dermatological care, physical therapy, and psychological counseling. Dental, oral, ocular, and genital sequelae are common and should be dealt accordingly. Now coming over to literature review. In US, a study was conducted in July 2023, in which data was collected over a 10-year period that showed total 51,040 hospitalization due to STS and TENS. Among those, 73% were of STS, 15.3% were of STS and TENS overlap, and 14% were of TENS only. We encountered 12 patients of SJSN10 over a span of 1.5 years, 4 of which were SJSN10 due to allopurinol. Other cases were due to quinolones, diclofenac sodium, lamotrigine, herbal medicine, and NSAIDs. So, in conclusion, SJSN10 are rare life-threatening conditions that require rapid recognition, prompt management, while treatment strategies continue to evolve. The primary goal remains to reduce disease impact and mortality by promoting responsible prescribing practices and through expert care. Here are some references that I used. On this note, I thank you all for your patient listening.
We chose to present this case because, as you all know, 10 is a dermatologist's nightmare. We wanted to highlight a few things. First of all, the rational drug prescription. So we were talking about the culprit drugs. So we need to carefully identify the culprit drug, and the patient should be counseled in detail to avoid taking that drug again. Even the cross-reacting drug groups should also be avoided. For example, in case of reaction to penicillin, the cephalosporins are the cross-reacting group. So these information should be carefully provided to the patient. Also, the blood relatives of the patient should be counseled to avoid these drugs because of the HLA association. We also want to highlight that we have seen a relatively very high number of 10 cases in Balochistan. Like you saw the data, in last 1 year, we saw 12 patients, which is a very high ratio. So this calls for the need for genetic testing because the facilities are not available and we could not test the HLA typing. In our experience, cyclosporin works really well for 10. It helps to halt the progress and aids in early recovery of the patient. Score 10 is the morbidity score. As you have seen in our patient, it was 4, which is associated with 62% mortality. But Alhamdulillah, our patient recovered really well, for which I would like to thank our multidisciplinary team. So the house is open for comments and questions, and then we will move on to the second case. So if anyone has a question, you can go ahead, please.
Complications in the according to the severity.
There is a high incidence of eye complications in 10 patients. Complications like scarring, cracker. Our patient recovered well. She had some scarring in the conjunctiva, and she was being looked after by eye specialist, and she's still on follow-up.
I'm asking about any detail in the literature review about blindness.
Yes, their blindness is reported with 10. And this is one of the very important complications.
Skin is actually the biggest problem in the body. And if you actually lose strong, very strong potential against the organ. So, like, then again, you have to prescribe immunosuppressive medications. So, you suppress the immunity, and the skin is not there, and the area is actually more inside surfacing their community. These are complications which can be due to that study. So, that way, this way you can also receive the vitamin and not the medication. The second thing is all of these drugs, I just put in under patterns, they do blood sugar levels. And when the skin is delivered, actually you go off of it. 35 and over the longer someone who cannot get over it, but sometimes they have problems in their intake as well. So you have to give any words that are going on their body. So I think we have a little bit of this means that we require more activities to prevent acute failure. And the third thing is they can develop the other complications, the regular mind, usually the government IDC issue, and IDC, you know, particularly around the world, the IDC part was very resistant to it. So doctor needs to cover with the
So if there is no questioning or comment from the online participants, then we'll move to the second case. So I would, जी sir, जी sir, please.
मैं कहना चाहता हूँ हमारे मार्केट है यहाँ पे ड्रिंक्स बड़ी ड्रग्स ले रहे होते हैं
जी sir.
कितना पॉसिबल है हमारे मार्केट में कि ड्रग रिकॉग्नाइज विजिट कर जब नगर पेशेंट रिकॉग्नाइज कर और मरीज को मतलब क्या तो क्या विड्रॉ करेंगे और कैसे स्टार्ट
As this is a hybrid activity, there has been some questions from the physical participants. So one of the question raised has been how to identify the culprit drug. As sometimes in our society, patients are on multiple drug therapies. So as we said, 10 needs a careful drug history of at least 1 month. The drugs started in the recent 1 month, and in some studies, they say even 2 months. They are the likely culprits. With antibiotic groups, the incubation period is shorter, like the reaction would start earlier.
Bismillahirrahmanirrahim. Respected audience, dear colleagues and faculty members, Assalamu alaikum. I, Dr. Asif Ahmed, Registrar Dermatology at Tertiary Care Hospital, Quetta, will present a case beneath the skin, beyond the heart, and the race against cutaneous leishmaniasis. Prepared under kind and able supervision of Professor Dr. Naji Ahmed, for consultant dermatologist, for which I am highly thankful. The objectives of this CPC is to explore the role of meglumine antimoniate in treating cutaneous leishmaniasis and to examine its potential cardiac effects and to create awareness about above used medication. The sequence of my presentation is as flashed. Coming first to case presentation. 23 years old patient from Punjab, posted in Panjgur, Balochistan, came to Tertiary Care Hospital, Quetta on 15th January 2025 with a history of non-healing ulcer on posterior aspect of right foot behind lateral malleolus from 45 days. According to my patient, he was posted in Panjgur 45 days back and was involved in outdoor duties. Presented with history of solitary non-healing ulcer over the posterior aspect of right foot. While there, he recalls developing a small painless lesion, a papule, at the site without any preceding trauma. Over the next several days, the lesion gradually enlarged and ulcerated centrally. The ulcer has shown signs of spontaneous healing. There is no associated systemic symptoms such as fever, weight loss, night sweats, generalized body aches, and lymphadenopathy. The chronicity and progression of the lesion has prompted the patient to seek further medical evaluation. He had no comorbidities and no known drug allergies in the past and belongs to middle socioeconomic class. A young male sitting comfortably with normal vitals and unremarkable general and physical examinations. On local examination, a solitary ulcerated plaque was observed over the posterior aspect of right foot. The lesion measures approximately 4 into 5 centimeter, oval in shape, with well-defined margins and raised and indurated edges. The surface of the lesion is ulcerated, showing central crusting, and is surrounded by a mildly erythematous base. The lesion exhibits occasional serous discharge, which is non-purulent and non-foul smelling. Mild tenderness noted on palpation. Local temperature is not raised. The lesion appears fixed to the underlying tissue, and the sensation is preserved over and around the affected area. No regional or inguinal lymphadenopathy is present, and there is no history of sporotracheoid spread. You can appreciate the solitary ulcerated plaque with mild oozing. Systemic examination was normal. Based on history and examinations, following differentials are made. Slit skin smear done and observation under microscope shows LD bodies. Section of the skin at 10x magnification shows granulomatous inflammation and interstitial infiltrate in the dermis. On 40x, infiltrate comprise of lymphomonocytes and histiocytes. Within the histiocytes, macrophages component, the presence of small round intra and extra cytoplasmic anti-LD bodies are present, suggestive of Leishmania A mastigote. On investigation, is weekly complete blood profile is normal with normal LFTs and RFTs. Diabetic profile normal. ECG on first day has normal sinus rhythm. Based on history examination and investigations, final diagnosis of cutaneous leishmaniasis was made. Patient started on injection meglomine antimoniate according to weight, IM once daily and cryotherapy twice weekly. For regular monitoring of the patient and on meglomine antimoniate, CBC, LFTs, RFTs done every Wednesday and ECG done twice weekly. On day 14th of treatment, patient's ECG show QT prolongation. After cardiology opinion, patient's treatment was revised, injection meglomine antimoniate stopped, and capsule multifosin 50 mg TDS started. After stopping injection meglomine antimoniate, cardiac monitors were attached. 12-hourly ECG was done to monitor the reversal of ECG changes, along with 3 sets of cardiac enzymes for monitoring. ECG was repeated for next 3 consecutive days. Cardiac enzymes and electrolytes are normal as advised by cardiologist. ECG shows QT prolongation, that is 16 small boxes. Normal is 9 to 11 boxes. After 3 days, QT interval reverted back to normal range, that is 9 small boxes. After 14 doses of injection meglomine antimoniate and 28 days of capsule multifosin, the ulcer showed improvement with complete with decrease in duration and size. A photograph demonstrating significant clinical improvement before and after management. After 42nd day, patient was discharged and adverse reaction to meglomine antimoniate was mentioned in discharge notes. Patient was advised to use long-lasting insecticidal nets when sleeping and wear long-sleeve, loose-fitted clothing and pants stuck into boots to reduce skin exposure. Use insecticide-treated uniforms and regularly apply insect repellents on exposed skin. And minimize outdoor activities during dawn and dusk. And avoid sleep outdoors. Summary of case presentation is as follows. 23 years old soldier, a patient posted in Balochistan, presented with non-healing indurated centrally crested plaque on right foot. All investigation were normal. Skin biopsy for histopath confirmed the diagnosis of cutaneous leishmaniasis, for which injection meglomine started. On day 14th of injection meglomine antimoniate, patient present with QT prolongation, which reverted back after stopping injection meglomine antimoniate. Treatment switched to oral multifosin. And after 4 weeks, ulcerated plaque showed complete healing and revitalization and patient discharge. Now coming over to case discussion. Leishmaniasis is a protozoal infection caused by genus Leishmania with wide range of clinical manifestations based on involved species. The parasites exist as 2 forms, 2 distinct forms, amastigote and promastigote. The vector for organism is a female, soundless female phlebotomy sandfly, smaller than mosquito. There are 3 species: Phlebotomus in Old World, Litzomia, and Psychodopicus in the New World. Its appearance is most commonly seen at dawn and dusk. They are weak flyers and do not disperse more than 10 to 20 meters. Can cross mosquito nets. Mostly bite at night. Seasonal activity ranges from April to November. Highest incidence May to September. Infection is transmitted by bite of a female fly, usually at night and outdoors. Optimum time for transmission is immediately after rainy season. However, infected vectors can take blood meal during a day if disturbed. Leishmania species is divided into New and Old World. The WHO estimates that around 1 million new cases of cutaneous leishmaniasis occurs globally each year. Cutaneous leishmaniasis with the highest rates of disease include Algeria, Brazil, Iran, Iraq, Syria, Afghanistan, Pakistan, and Colombia. It is a significant public health issue in Pakistan and is found in all provinces, with Balochistan being the most endemic area. In Quetta district alone, 5,032 cases of cutaneous leishmaniasis were reported between January 2024 and January 2023 and January 2024. Life cycle of parasite is as follow. Promastigote, there are 2 stages involved. Sandfly and human stage. Promastigote stage is sandflies gut. Promastigote multiply and migrate to sandflies proboscis, ready to infect human host. The human host is body. The human host body in human body comprise of amastigote. Amastigote multiply within the cell, infecting various tissue, and the cycle continues when another sandfly take a blood meal. A minority of successful parasites inoculate results in clinical cutaneous leishmaniasis after a period of time which depends on parasites species, size of inoculum, and the host cellular immune response. A clinical lesion appears. The lesion comprises parasitized macrophages, lymphocytes, plasma cell, and little structure. The incubation period is usually measured in months, but range from a few days over a year. 1 or more lesions occur on exposed part of the body, particularly on acral skin over bony prominences that are easily bitten by phlebotomus, usually in a child. The face, neck, and arms are the most common locations. The most common presentations are papules, nodules, ulcers, and plaques at the site of sandfly bite. The crust develops centrally, covering the ulcer with raised edges and variable surrounding in duration. If left untreated without therapy, lesion usually heal gradually over months or years, usually leaving a depressed scar. In cutaneous leishmaniasis due to Leishmania major, also known as rural or zoonotic cutaneous leishmaniasis, multiple ulcerated wet skin lesions are present. They cause more severe destruction. Self-healing is around 3 to 6 months. In dry type, caused by Leishmania tropica, also known as urban or anthropogenic cutaneous leishmaniasis, usually there is single lesion. Self-healing is after 6 to 12 months. A number of disorders can present with similar presentations. If untreated, they may cause disfigurement and scarring, secondary infections, chronic conditions, mucocutaneous leishmaniasis, impact quality of life, consequences. A positive diagnosis of cutaneous leishmaniasis can be suggested clinically. In most confirmed cases, in most cases confirmed by presence of 1 or more of the following: history of exposure to an endemic area in the previous weeks or months, history of sandfly bites in previous weeks or months, History of high-risk activities such as sleeping outdoors, jungle or desert trekking. History of non-ailing chronic nodular violaceous ulcer for 4 to 6 weeks. Demonstration of intracellular hemastigote in dermis of H&E section of skin. Presence of leishmanial granulomas in dermis in H&E specimen. Hemastigote in triple N culture medium for leishmanial specimens, and demonstration of leishmania by PCR. Biopsy of early lesions showing abundant hemastigotes in macrophage and a few epithelioid cell granuloma as seen in cutaneous leishmaniasis. Now coming over to management. Antimonials are first line antimonials 20 mg per kg per day IV or IM OD for 30 days or more. Amphotericin B deoxycholate 0.7 to 1 mg per kg IV. Liposomal amphotericin B dose 2 to 3 mg per kg IV OD for up to total dose of 40 to 60 mg, and multifosin 2.5 to 3.3 mg per oral OD for 28 days are first line. Second line anti-leishmanial drugs, the patient in whom parental antimoniates are contraindicated, unavailable, or have problem related to tolerance and toxicity. The following second line anti-leishmanial drugs can be used: allopurinol, dapsone, rifampicin, metronidazole, ketoconazole, fluconazole, pentamidine, and trimethoprim sulfamethoxazole. Now coming over to literature review. The literature review focus on the age of distribution patients diagnosed with cutaneous leishmaniasis in Mashhad, Iran. During the period from 2015 to 2018, a total of 5,241 confirmed cases were reported across a wide age range from 1 to over 80 years. Highest proportion of cases occurred among children aged between 1 to 9 years, accounting for 22%. These figures suggest that younger population were more frequently affected during the period, highlighting a potential age-related vulnerability to cutaneous leishmaniasis in this region. In our hospital, 217 patients received meglumine antimoniate for treatment of cutaneous leishmaniasis over a span of 1 year. 49 out of them developed ECG changes, 31 of which developed T-wave inversion, 12 had bifid T-wave, 4 of them had bradycardia, and 2 of them developed QT prolongation. For patients with non-specific T-wave inversion or bifid T-waves in a single lead or for heart rate of around 60 beats per minute, injection meglumine antimoniate was not stopped. However, cardiologist opinion was taken for each case with serial ECG monitoring, cardiac enzymes, and echocardiography. In conclusion, prevention of meglumine antimoniate cardiac effects relies on careful patient selection, baseline and ongoing ECG, and electrolyte monitoring, avoidance of interacting medications, prompt discontinuation of causing drugs, management of any cardiac symptoms during therapy. Here are some references I use. Thank you all for your patient listening.
As you all know, Pakistan is located in the cutaneous leishmaniasis is a significant health issue that we are facing in all provinces, including AGK. Globally, world over, about 1 million new cases occur each year, and out of which about 21,000 to 35,000 are in Pakistan, and 5,000 are in Quetta district alone. As you all know, anti-money compounds are the gold standard and the first line treatment that we use, but it is a toxic drug. can create multiple side effects like toxicity, nephrotoxicity, hematotoxicity, and cardiotoxicity. So we chose this case because we wanted to highlight the importance of ECG monitoring for patients on meglumine antimoniate. Our patient developed asymptomatic QT prolongation, which was picked up in time, and we stopped the drug, and the change was reverted in 3 days. We want to highlight that high-risk cases should be especially monitored, and meglumine antimoniate should not be combined with other cardiotoxic drugs like quinolones that we commonly use, macrolides that we commonly use. So they increase the chances of cardiotoxicity and the QT interval prolongation. Another drug that we commonly use in dermatology are the azoles. So they should also not be combined with meglumine, and some other drugs like antidepressants and opioids, etc., antimalarials, they also need to be careful about. So good thing about the ECG changes are that they usually revert to normal once the drug is stopped. And but if they are not timely picked and drug is not stopped, then it can lead to sudden cardiac arrest and death. So if there are any questions or comments from our online participants, please, you're welcome.
Assalamu alaikum. Can you hear me, Dr. Nadia?
Yes, Dr. Romero, we can hear you.
Thank you so much, Dr. Nadia, for coming forward and presenting these two common cases we usually come across in our day-to-day practice. I would like to congratulate your trainees and Dr. Nadia to that they have brought such common cases in such a well presented and well worked up cases. And I would like to ask one question, Dr. Nadia, that most of the time in Karachi, whenever we receive patient of TENS or Steven Johnson, the drug is not mentioned because most of the GPs are giving different types of medications. At that time, what should be our strategy? Either we are going to hold all the drugs, that is not possible because most of the patients are young. I think last year, 3 females presented to us and they had severe reaction. And at that moment, what should be our strategy? How should we diagnose those cases and which drug should be stopped?
That's what we have already emphasized, that we need to take a very careful drug history for at least 1 month and preferably of the 2 months. So drugs का ये कि हमें ही careful history elicit करनी है, and we have to make all efforts to find out the drug. Like we saw 12 cases of 10 in 1 year, and we were able to elicit drug in all of these cases, and all of these cases were on polypharmacy. But we have to find out the culprit drug, and we have to make every possible effort. Sometimes we cannot pinpoint one single drug, like in the case we presented, allopurinol and etoricoxib. So allopurinol has more incidence of the side effects. So we would suspect it as #1 culprit, but we could not rule out etoricoxib at all. So we'll put these 2 drugs on surveillance, and we'll counsel the patient not to use any of these 2 drugs. So we can narrow down the spectrum at least, if not one culprit drug, but we should make all possible efforts to identify the exact drug.
Thank you, Dr. Nadia, once again, and many congratulations. Thank you.
We have Dr. Bilal Shams with us. Physically, he's present, so he wants to make a comment.
So as far as the duration of treatment is concerned, I have seen the cases of cutaneous leishmaniasis, over the acral parts of ear lobule and tip of the nose, as well as lips. They take more longer period of therapy as compared to cutaneous leishmaniasis occurring over other parts of the body. Even on different parts of the face, suppose the lesion is on the cheek, it responds very well to short-term therapy like 21 days of antimonials or even on other parts of the body. But as far as the tip of the nose as well as ears or lips are concerned, it takes longer treatment duration. Anybody else has seen this occurrence or not? This is This is what I have seen. What could be the possible reason behind it? Probably some blood flow issue, or what else could be? But as far as the lips are concerned, it has got a very sufficient blood supply, but still the lesions take longer as compared to other parts.
I think there are multiple factors involved in response to a drug. First of all, the species. Different species have different response to drug, and we usually do not have the facilities to identify the exact species. We know from research that in our area, Leishmania major and Leishmania tropica are the two most prevalent species. Sometimes we have Leishmania donovana infantum, but identifying the species. Now at some labs, they have developed the PCR for species identification like in FIP. So we are sending some of our patient samples to FIP for species identification as well. So species identification is important for this response also, because different species respond differently. This is already established for some new worlds like Leishmania mexicana, etc. The minimum treatment duration is 3 months because they are slow responders. Then second factor can be the dose inoculum, the amount of infection that has been acquired. And then, of course, the host immunity and the host response to treatment. And then there is also one important thing, the quality of the drug. Sometimes the drug is not original and the efficacy is not up to the mark.
Well, these explanations, I didn't find the exact answer in these explanations. The reason is the same species infecting the same patient in these parts. Why do they respond longer to the treatment option? Suppose we use the same drug for all the patients, but in this case, when we tell the patient like you have to take antimonials for 21 days, they come back and the lesion remains the same. So we have the same medication, another course of the same medication. So I don't understand what could be the reason in these specific sites.
One of the reasons, as already mentioned, can be dose inoculation. The bite and the material injected from that bite can be different in the same person at different sites of sandfly bite. And then maybe Dr. Bilal can conduct some more research on this to identify other causes as well. There can be multiple causes.
Yeah, it needs further research. I already published 2 to 3 research papers on cutaneous leishmaniasis, but this aspect needs to be evaluated further.
Thank you very much, Dr. Bilal, for your comments. I would like to invite any other comments. Dr. Rabia Ghaffur, are you with us? If there are no more comments from our online members, I would like to thank Dr. Uzma Ali, Dr. Sadaf, Dr. Rabia Ghaffur for joining us online, Dr. Humaira Talat, of course, for providing this platform. And I think Madam Yasmina Khan is with us online. Madam, are you there? Madam Yasmina? Okay, maybe she's not responding. Then I would like to invite Dr. Sara Inayat for her comments. She's also with us physically. Dr. Sara, would you like to make some comments?
Assalamu alaikum. I'm Dr. Sara Inayat, professor and head of Department of Dermatology. Thank you, Dr. Nazio, for inviting us and sharing your experience regarding cutaneous leishmania development. I was a bit late in the early cases, but I did catch cutaneous leishmania, so you would think that it is indeed very important and very resistant. Despite multiple treatments, I think we are still, there's a puzzle and there's a mystery that most of the patients of glutathione and leishmaniasis on patients on glutathione, multifosin, cryotherapy, thermotherapy do not respond as well. So thank you very much once again for a very useful discussion. Thank you.
Thank you, Dr. Sara. Dr. Irfan Tareen, a very senior dermatologist and PAD appointment holder, our vice president from Balochistan. Sir, please.
Thank you very much for a very good talk on both of the topics. And this is sort of joint venture of Pakistan Association of Dermatologists, which I am representing here as a vice president, and my rest of colleagues, especially the executive member. Both of the talks were very informative. Undoubtedly, we need lots and lots of aspects to cover. As far as 10 is concerned, I would like to say that in Pakistan, we can get any medicine anytime, anywhere. So still, it is not reported properly. If we see the world statistics and we compare ourselves, I think we have more patients. And as far as leishmaniasis is concerned, we are living in den of leishmaniasis. And definitely, we have to share our experiences. And I would like to see all the institution collaborate in such research papers and such research talks, which will enhance our knowledge. And this is how we should go on. Thank you very much once again for your invitation. Really nice. Thank you.
I would now like to invite Professor Arif, our principal of QIMS. Sir, please.
शुक्रिया बहुत बहुत इनवाइट करने का और वेरी नाइस प्रेजेंटेशन. I will take only few minutes now as a principal of an undergraduate medical college. What I want to convey the message that in the first presentation, as the presenter has mentioned, that the patient after get the prescription, she went to the physician again, but he didn't notice anything, and the patient is continue the same medicine. So this is very alarming thing. And Professor Ashfaq is sitting here, and usually I used to say कि स्टूडेंट ने क्या करना है क्लिनिकल प्रैक्टिस में वो बहुत जल्दी सीख लेते हैं, लेकिन ये कि उन्होंने क्या नहीं करना है या उनको क्या एरर्स जो है वो अवॉइड करने चाहिए. क्योंकि throughout my career I have seen so many things due to the negligence and errors, the patient died or severe complications are occurred.
यही कहूँगा कि बहुत अच्छी प्रेजेंटेशन थी दोनों. ठीक है, 10 भी काफी हमारे सोशल जो एनवायरनमेंट है वहाँ पे काफी ज्यादा है. लेishmaniasis भी बहुत ज्यादा है. ठीक है, लेishmaniasis भी बहुत ज्यादा है. लेishmaniasis के हवाले से मेरा क्वेश्चन था कि जैसे और वायरल डिजीज जहाँ पे एंडेमिक वगैरह होती है तो वहाँ पे वैक्सीनेशन वगैरह होती है या उसको प्रिवेंट किया जाता है, तो लेishmaniasis को कैसे प्रिवेंट किया जाता है? जैसे यहाँ पे दो बताए उन्होंने, इंसेक्टिसाइड्स जो स्प्रे होती है नेट्स पे वो हम लोग लगा सकते हैं. ठीक है, लेकिन फिर ये भी मैंने सुना कि ये सैंडफ्लाई जो है ये मॉस्किटो से छोटा है, तो ये मॉस्किटो नेट से गुजर सकता है. ठीक है, तो फिर मेरे जहन में आया कि मैंने कि फ्यूमिगेशन हो सकती है इस तरह के जगहों में या नहीं हो सकती जहाँ पे एंडेमिक हो, क्योंकि मैंने रिसेंटली अभी MSF से डाटा इकट्ठा किया कि कहाँ कहाँ पे ये प्रिवेलेंट है ज्यादा. ठीक है, जैसे फरोटाबाद हो गया, बाईपास हो गया, मरियाबाद हो गई. तो MS ने कहा कि मुझे ये डाटा फराहम करे ताकि फिर मैं DG को लिख सकूं और फिर वहां पे फुमिगेशन करा सके हम लोग. तो आई होप कि फुमिगेशन जो होगी इन जगहों पे इफेक्टिव होगी और प्रिवेंट करेगा स्प्रेड ऑफ लेishmaniasis, बिकॉज हम लोग हमेशा कहते हैं प्रिवेंशन इज बेटर देन क्योर. तो मैं कहता हूँ कि ड्रग लोड भी फिर कम होगा. ठीक है, रेजिस्टेंस भी फिर कम होगी. ठीक है, और ज्यादा जो सेकेंडरी ड्रग्स है, सेकेंड लाइन ट्रीटमेंट ड्रग्स है, उसकी भी जरूरत कम पड़ेगी, जो ज्यादा फिर वो है टॉक्सिक वगैरह हो सकती है. वैसे भी हमारे पास मेरे ख्याल में ये मिल्टीफॉर्सिन वगैरह ये चीजें जो है ठीक है काफी एक्सपेंसिव होती है, हर कोई जो है वो बर्दाश्त नहीं कर सकता. सो मैं कहता हूँ कि प्रिवेंशन पे ज्यादा जोर देना चाहिए. ठीक है, आला हुकाम से बात करें. ठीक है, जहां भी हो सके. ठीक है, थैंक यू.
I would also like to thank Ashfaq and Dr. Zain Niaz, Commandant QIMS for gracing this occasion. Thank you very much, and thank you very much on online participants. And I'm sorry if I left any important name because some participants didn't log in with their original names. So thank you very much.